All right. How's the PEDS test? Anything from my lecture yesterday may have informed anything on that test? Maybe? Nothing? Oh, sorry. I have a little bit of overlap, but I tried. Oh well. I actually had no idea what was on your test, so anyway. Okay, any questions about stuff from yesterday? Shh. Not you. Yeah. Or combi? Yeah, it's easy. Yep. What are the indications for that? Is that for like any system? They recommend it for if you have that specific, if you're homozygous for that Delta F508, I think, mutation. So that was like what it was specifically indicated for. Does it have efficacy for kids with that are maybe homozygous for that or have a different mutation? Potentially, I haven't honestly gone that much into detail, but if they test you and you do have that that mutation, then that seems to be what the indication is for specifically, and that's the most common one you're going to run into. It will help. You know, I don't know if one's particular system gets much more benefit than another, but ideally it would help with kind of all issues with that, right? Because again, it's helping to get more of those transporters up onto the cell surface, and it helps those that are there to work better, right? So. Any other questions I can answer for you? All right, well, let's go on to the urology section. So this is another one of my most awkward lectures to talk about because we get to talk about erectile dysfunction. Fun stuff. All right, what do you use for erectile dysfunction? Sildenafil, it's a good one. What's the brand name for that? Viagra, cool. What else? Cialis, a good one. What about non-pharmacologic stuff? A big needle? I don't know what you're into, man, but. So we'll talk about some other means. I'm glad I can educate you on some other non-pharmacologic means. We'll talk about those in a second. It's kind of interesting. You can actually use inflatable pumps that can be installed into the patient, implanted, I should say. And one of my advisees who's on rotation, or his previous rotation in urology, said, yeah, they were just doing that all day long. The urology, I was just putting in these inflatable pumps, and like 97-year-old dudes come in, want these pumps in place, and some of them, their arthritis was so bad that they didn't want to have to deal with the pump anymore because it hurt their hands, so they just leave it inflated all the time. Okay. Very interesting. Anywho, so what's our definition of erectile dysfunction? Have you covered it in anywhere else yet? So you had urology already to some degree, right? Yeah, failure to achieve or maintain an erection. Usually consider this for, say, 3 months or more. In other terms, impotence, we can talk about this. Certainly there's this is a different problem than just decreased libido, ejaculatory disorders, infertility. This is a different problem than that. What could be a cause for decreased libido in male patients? Low testosterone levels, low DHT levels. So this is one of those things where we can't fix that problem with these medications. However, if that's a concomitant issue, yes, you can address that. But it's important to look at other factors that may be playing a role with this. Can any medications cause erectile dysfunction? Absolutely, yeah. So we'll look at some examples of those that can do this in just a little bit. And it's important to look at the medication list because a lot of these are going to be medications that these older gentlemen might be on anyway. And so it's important to evaluate that list to see if you can maybe switch them over to something else. Maybe they don't need any specific therapy for this in the first place. Anyway, so typically older men will be experiencing this, and you're more likely to have this, especially if you have any kind of arterial disease, you have hypertension, arteriosclerosis. You see this more like diabetes, especially if you get more kind of the microvascular damage being done over time. And then we'll look at the medications that can do this as well. So what is the actual physiology happening here? So again, typically you're going to have two corpus cavernosum here. And so during the flaccid state, you have a pretty good balance between arterial and venous flow. However, during the erected state, you're going to find there's going to be increased arterial flow, but decreased venous outflow. So basically kind of blocking off the outlet, and then that will allow for the erection to occur. And then there you go. So if we had to treat this with medications, what are some things you think we could do to fix that? So you think maybe a vasoconstrictor. What you're actually going to find, though, is we're going to use things that are going to be vasodilatory. We're actually going to try to increase the supply heading in, and that will actually cause the erection to occur. So we'll look at some medications that can help with that in just a little bit. That's where a lot of our phosphodiesterase inhibitors, namely their sildenafil, your Cialises, your Levitras, that's where this is going to work on this system here. So again, things that are going to affect this arterial flow, you're going to see this is going to be mediated by acetylcholine, and again, mediated by the nervous system. You're going to see there's increases in cyclic guanosine monophosphate. If you remember, CGMP is typically going to be vasodilatory. If you remember back to, say you're having a heart attack, what do we use as a vasodilator? Use nitroglycerin, absolutely. What does nitroglycerin provide? It provides vasodilation by giving off nitric oxide. Remember, nitric oxide stimulates that CGMP pathway, right? So it's going to help to stimulate production of cyclic GMP. That's going to be vasodilatory. Do you remember what broke down cyclic GMP? Phosphodiesterase. Yeah, so keep that in mind because it's going to be important when we're talking about the medications we're using here. Anyway, there's some other products here as well, but just remember nitric oxide stimulated in the endothelial cells will increase cyclic GMP. That's going to decrease the amount of calcium being released there, and that's going to allow for that smooth muscle to allow it to dilate some. So you're going to have some vasodilation that happens there. Other things that can affect this are going to be acetylcholine, obviously, and prostaglandin E. This is going to be important for medications that work through the prostaglandin system. This will be important when we talk about alternatives to some of our phosphodiesterase inhibitors, your sildenafils, in just a little bit. But they can also help to increase levels of cyclic AMP. This will also have a vasodilatory effect and will increase blood flow. So now you have to have a psychogenic stimuli, right? So again, what you're going to find in kind of a common misnomer, especially by, or not misnomer, maybe misconception by lay people, is they think like as soon as you take a Viagra, you just immediately get an erection, and then if you have it for more than 4 hours, what do? Call your. I always say it in the commercials, if you have an erection more than 4 hours, call your doctor. But it's not really the case. You still have to have that psychogenic stimuli. You still have to have that stimuli that says, hey, I'm about to have sex. This is going to happen, right? Those nerve impulses still need to happen there. And of course, this may not fix an issue. Say if you have something like a spinal cord injury, where you kind of sever that link, like this may not be able to fix that issue there, right? Because again, you still have to have that process going there. And so you're going to find that a couple of things that can work to help to integrate those kind of external stimuli to, trying to start to activate those nerve signals. You're going to find that dopamine is going to be exhibiting a pro-erectogenic effect. So again, while you're friends with the term pro-erectogenic, pretty good one, right? And so if you imagine what kind of drugs could maybe interfere with this? What kind of drugs block dopamine? Dopamine antagonists, otherwise known as antipsychotics. Yeah, antipsychotics, right? They block dopamine. So imagine someone that has, schizophrenia, or they have maybe treatment-resistant depression or bipolar disorder. You can imagine how this could interfere with that, right? And so we saw that, a lot of those medications, you can end up having, issues with, erections and ejaculatory disorders and other things like that. Again, dopamine is important for this process here. And then alpha-2 stimulations will also stimulate. Actually, alpha-2 stimulations will inhibit erections. Remember that alpha-2 is going to be a sympatholytic sort of effect, right? That's what kind of decreases the release of that sympathetic nervous system, less norepinephrine and epinephrine. You remember any drugs that affect alpha-2? Clonidine, yeah, so clonidine and guanfacine. Remember, those are activating alpha-2. There's decreased norepinephrine levels. There's going to decrease heart rate, blood pressure. That can also have an effect on here. You can see basically, a decreased ability to, maintain and sustain an erection for those patients who are on, say, something like clonidine. So we can already start to see where patients who are on antihypertensive medications, this can become an issue for them. So look at other meds that can affect that as well. But these are things that you kind of start keeping in mind. Now, usually detumescence, which again is a fancy way for saying, kind of going back to the flaccid state, it's going to be mediated by norepinephrine. And so basically it's going to be contracting that vascular smooth muscle, and that will decrease arterial flow. So you kind of go back to that balanced arterial versus venous flow. And then venous flow outflow will increase, and then you're kind of back to your normal kind of baseline state there. So norepinephrine is important from that standpoint. We're not going to find too many medications that are affecting that pathway. Mainly we're going to be affecting the arterial flow with our medications. Anyway, looking at hormonal effects, testosterone is going to be important here. Obviously, this is going to be stimulating the libido. If you don't really have any libido, it doesn't matter if that whole nitric oxide pathway is working or not. You really just don't have that stimulation to start an erection in the first place. However, things that can affect testosterone levels can affect this pretty significantly from a libido standpoint. So remember, testosterone is the less potent form than DHT, or dihydrotestosterone, and so that important enzyme there, 5-alpha reductase, is going to be really important here. We know that we get to the BPH section a little bit later on, we'll talk about that there, but this will be important when dealing with patients who have BPH, kind of too much DHT activity. We'll try to limit that, but that can also have effects on their libido as well. So you're going to see some interactions there. Now, of course, small amounts of this will be converted over to estradiol. Do you remember the enzyme that does this? Yeah, aromatase is important there. So that can cause some gynecomastia. But you need to be careful with patients who are experiencing erectile dysfunction and trying to interpret testosterone levels. You may find they could be normal in some cases, and so you need to look at maybe potentially free levels to kind of help with that. And then looking at trying to determine, is it really just decreased libido or is it an actual erectile dysfunction? What's kind of the issue here? And so once you kind of delineate that, you can figure out, well, maybe I don't need Viagra, maybe I just need to hook them up with some testosterone, and that will kind of fix the issue here overall, right? Okay. So some causes, some reasons why we can have erectile dysfunction. It can be vascular issues. So we have like peripheral vascular disease or arteriosclerosis that can affect the ability to kind of modify that blood flow. It can be an issue. It can be neurologic issues. So things like stroke, spinal cord injuries, we've kind of already alluded to. Diabetes can affect this, and the hormonal factors here as well. So especially if you have patients like testicular cancer, they had that removed. That can be a major source of testosterone gone. Hyperprolactinemia can be another cause for this. So lots of different things here. When I say psychogenic erectile dysfunction, what do you think that means? Maybe trauma. Kind of a hard time to be able to incorporate those kind of external stimuli and turning that into like sexual desire. So for instance, the thing I think about this most frequently is what kind of medications could potentially say decrease your ability to really know that you're coming into like a sexual sort of situation. It's kind of a hard way to put it, but yeah, potentially opioids. What do opioids do? Yeah, sedation, right? So again, if I'm passed out, I'm not going to know that I'm going to be in the kind of a sexual situation. I'm not going to have that reflex starting to kick up, right? What other drugs could do that? Maybe not antidepressants. Maybe like some more of the sedating ones. You can certainly see like tricyclics. Benzos are a big one. What do you call so say you're going out for date night on Friday night. What might you consume with your dinner? Alcohol. You got to make sure alcohol is not a big feature here, right? So again, if you're over drinking, that can also lead you to have a kind of a blunted CNS. You may have a psychogenic form of erectile dysfunction, right? These are things to keep in mind. Make sure substances are not going to be involved here. Again, it could be multifactorial. Okay, so there's another thing to consider. Remember, make sure the patient's kind of in the proper frame of mind. Sometimes they have a reactive depression or things like performance anxiety, Alzheimer's. All of these things could be affecting their ability to kind of turn those external stimuli into that kind of internal reflex arc. So these are things to watch out for. Mental disorders, dementia. These are all things that are going to kind of inhibit that ability to activate those reflexes appropriately. So, but medications, let's look at these. 10 to 25% of cases of erectile dysfunction can be linked back to your medications. This is why it's so important to look at the medication list and make sure you're evaluating that to look for anything you can DC or maybe switch over to different agents. Certainly things like anticholinergics can play a role here. So things like antihistamines, anti-Parkinson drugs, tricyclic antidepressants. We already know antidepressants have a lot of sexual dysfunction associated with them anyway. Phenothiazine, so I mentioned phenothiazines are what type of drugs? You see, you think antipsychotics, right? So think about your first generation, your typical antipsychotics, right? Things we can do to help prevent that. So we can do things, and again, because antihistamines are typically what? Sedating, right? So again, that can be one of the causes there. You can utilize things like second generation antihistamines. Do you remember any of those? There's Allegra or anyone? Fexofenadine. What's another one? Zyrtec, which is what? Cetirizine. There's loratadine, which is Claritin, right? So good. Be able to kind of recognize the brands and generics, things like that. Good. So you can utilize the second generation. Why are those less sedating? Don't cross the blood-brain barrier. Absolutely right. So they have much less sedating. You have much less chance of activating those kind of or causing the same sort of CNS effects. Now remember, when we're looking at antidepressants, which one is going to be the best for not causing sexual dysfunction in patients? Well, bupropion, that's always going to be the one to go with if they experience sexual dysfunction related to like SSRIs or SNRIs. Typically, you're going to find SNRIs are a little bit better than your SSRIs. However, they still can do it. Bupropion is going to be the best from that standpoint. Okay, that's always kind of a good go-to drug for that. We mentioned dopamine antagonists, phenothiazines, metoclopramide, which another name for metoclopramide is Reglan, which we use for motility, nausea, vomiting, right? So several uses for that drug. And again, looking at those dopamine blockade will increase those prolactin levels, and that tends to have a negative effect on testosterone production, right? So it kind of makes sense from that standpoint. Other things, anything that's going to be affecting testosterone, so things like estrogen-based products, anti-androgens, and things like spironolactone. We mentioned spironolactone does what at the testosterone receptor? It's only a partial agonist, right? So you only get kind of partial effects, so it can diminish the testosterone effect of what's floating around for a normal guy, right? Cimetidine can actually have some negative effects on here as well. All these are basically due to suppressing testosterone, right? So it's not truly erectile dysfunction in the sense that we're talking about from kind of the mechanical aspects of it, but certainly from the testosterone, the hormonal standpoint, this can be an issue here. And then we said CNS depressants. This is a big thing with suppressed perception of psychogenic stimuli. This is a big one. So benzodiazepines, opioids, large amounts of ethanol, anticonvulsants can do this as well. So anything that's CNS depressing can lead to this issue here, right? All right. Things that can affect and decrease blood flow. You can see things like diuretics, right? So if you're decreasing blood volume, that may decrease blood flow because ideally your body's trying to provide blood to which two organs? Heart and the brain, right? So unfortunately, your genitalia take kind of a backseat to that. So again, decreased blood volume, decreased blood flow. Beta blockers, central sympatholytics, such as you mentioned, clonidine. All these are going to be decreasing blood flow. This can cause antihypertensive induced erectile dysfunction. We can do things like utilizing ACE inhibitors or ARBs. These tend to be the safest from that standpoint, not causing any kind of erectile dysfunction. So this may be a good option to switch to if you had a patient who's experiencing that. And then also calcium channel blockers tend to have a lesser effect on that as well. Kind of makes sense because, again, these are going to be blocking calcium channels. These typically do what to smooth muscle contraction? They normally inhibit that, right? Because that's how they lead to causing vasodilation, right? So that kind of makes sense. And then other miscellaneous agents, we'll talk about finasteride and dutasteride. Those are 5-alpha reductase inhibitors. We'll talk about that a little bit later in BPH. That'll be important for decreasing DHT levels. Lithium carbonate also tends to have and what do you use lithium for? Yeah, bipolar disorder mainly. Things like monoamine oxidase inhibitors, even something like gemfibrozil. Anyone remember where we saw that before? Yeah, hyperlipidemia. So again, even that one, again, I don't know the mechanism for that, but it seems it just is something that's been associated with that. So again, look at the med list, run it through an interaction checker to see if this is maybe one of the problems, if you can switch to something else, right? It's also a good source for test questions, potentially. So something to think about. Okay, so again, make sure you go through a medication list, get a thorough history, concomitant disease states, if they have diabetes, try to get that under control, peripheral vascular disease, and these are things to assess for. Do your physical exam. Testosterone levels can be somewhat helpful, especially if you're thinking they're kind of in a low T sort of state, based on other kind of findings. But basically, let's get into the actual treatment. What are we going to do for these patients once we've established, yes, they have erectile dysfunction, want to give them something for this? Basically, our goals are to improve the number, quality of erections they can experience. Make sure they have reasonable expectations, right? So make sure you're kind of educating them on, listen, this is only not something you take every single day. It's something where you need to kind of be able to kind of anticipate when you're going to need it, and make sure you're taking it kind of on an as needed sort of basis, right? So it's something to think about. So again, if you're writing your prescription for your assignment and you said, take Levitra every day, some people may need it every day, but some people are not in that sort of situation. Probably only going to be as needed, right? So it just depends on their situation. Only patients with legitimate complaints. What do you think that means? These are not to be used as performance-enhancing drugs in otherwise healthy adult males. Okay. Sometimes in certain organizations you have to manage your phosphodiesterase inhibitors as a controlled substance due to diversion by people working in the institution. Okay. So again, you'd like to think all healthcare workers are there being honest and doing their best. Not always the case. There is some diversion that happens with this. And make sure it's not like some strapping young 21-year-old coming in like, hey, I need some Viagra. No, you probably don't, right? So keep that in mind. And once something's going to be well tolerated, there are side effects associated with these, and then also for a reasonable cost. Now remember, I said sometimes we'll actually give little girls Viagra. Do you remember what we use that for? Yeah, so we'll talk about why that is in a little bit later. So just know that sometimes it's not always going to be like your middle-aged guy who's going to be getting these drugs. Sometimes you'll find some abnormal uses, and we'll talk about why that is based on the mechanisms here in just a minute. Okay, so obviously correct underlying issues here if we can, and then a few other therapies, which I'm not going to get too much into these, but we're going to talk about briefly vacuum erection devices, some limitations with that. There's surgery, which I mentioned you can have like implantable pumps and things like that that can be very useful. Some of them are even kind of like a prosthetic, where it's almost like the thing I think of in my mind is, remember like playing with like Barbie dolls or any kind of like toys where you have like the opposable limbs? No one did that. It's kind of like that though. Basically, it's like an opposable sort of thing. You just kind of change the shape, and there you go. But the pharmacologic therapy is what we're going to focus on primarily. So anyway, so ideally, they should be pretty fast acting, should be efficacious, should be pretty convenient. And also one of the things we're going to look at is going to be the discreteness of some of these therapies. So for instance, what do you think is more discreet? Taking a tablet or having to get out a vacuum erection device? Probably the tablet, right? So these are things to consider, what's going to be best for your patient. Again, not one thing is right for every one person, so always keep this in mind. Generally, we try to go with least invasive to the most invasive. So you can try things like, our typical standard medication therapy before going to things like surgery, right? So it just depends. All right, so the general flow here, and we'll talk about the medications in just a second, but basically what you're going to do is, again, once you kind of figure in all the other treatment of underlying diseases, getting rid of medications that could be affecting this, all of that, then you're going to look at our phosphodiesterase inhibitors. These are our gold standard go-to drugs for erectile dysfunction. And then if that's effective, you go ahead and continue with that. In some cases, it may be contraindicated from receiving that, and that'll be important in figuring out who should not get phosphodiesterase inhibitors. And that's where we can think about things like, we'll talk about intracavernosal or intraurethral alprostadil. That'll be one alternative. And then again, thinking about things like either prosthetics or implantable pumps, things like that. So again, go least invasive to most invasive. And again, how do you get drugs intracavernosally? You got to inject it, right? More invasive than a tablet. So again, this is kind of the stepwise approach. Tablets are pretty easy. We'll go start there and go from there. Okay. So again, basically with the vacuum erection devices, these are pretty effective, very good at what they do. However, not super, pretty conspicuous for the most part. Again, it takes time to say, hey, let me go use this device, so it can be sometimes kind of an issue. It takes 3 to 20 minutes, so again, time frame can be kind of important there from that standpoint. But overall, people do like it. However, it's not going to be, or it's going to be better for patients who cannot receive phosphodiesterase inhibitors. So when I say PDE5, that's what I'm referring to as phosphodiesterase 5, right? So again, it's going to be good if they're contraindicated from receiving that. Vacuum devices are great. And sometimes they'll use it prior to actually going for surgery. So it can be one stop there. This is all I'm going to talk about those, because again, it's not really my wheelhouse, so to speak. However, we do have our phosphodiesterase inhibitors, and this is more my my realm. So anyway, not from personal use, just from dealing with it on a pharmacology standpoint. Anywho, right, so the pathway here we're seeing is that you're going to have sexual stimulation of the patient. You will then release nitric oxide from those nerves into the endothelial cells. That should cause cGMP to be formed in higher amounts, right? So you're going to up cGMP production there. And that is going to be blocking calcium inflow. And by doing that, you're going to cause vasodilation, okay? cGMP is then metabolized by phosphodiesterase, and it will be broken down into more soluble components, can be potentially reused. What we're going to do is inhibit that breakdown in cyclic GMP by using our phosphodiesterase inhibitors. Okay, we're going to have 4 main ones we're going to see used here. I'll talk about those in a second. But you're basically preventing cGMP from being broken down, and that will lead to more smooth muscle relaxation on the arteries, allow more blood flow. Okay. So the 4 that we have are going to be sildenafil. This is probably the main one that came out first. Then we have vardenafil, tadalafil, and avanafil. Anyone know why we might choose one versus another? We'll talk about why in just a minute, but we're going to see some of it can be related back to side effects. Some is going to be related back to duration of action of the drug. Some is going to be related back to things like insurance, obviously, what can the patient get coverage for, things like that. A lot more insurances are starting to cover these more nowadays than they used to. I remember when I was interning, let's see, this was back in probably 2007, I would say, just to date myself. When I was interning, it was like my first, out of my first year of pharmacy school, I was interning at this CVS. And a lot of insurance companies did not cover Viagra. That was like really the main one we had out at the time. And you'd have these guys that would come up and they would basically have their prescription and say, I only need 1 pill. Of course, they come in, they're like, it's Friday night, coming in, they're like dressed to the nines, and say, I only need 1 pill. Cash. And I was like, okay, we'll give them cash. It was very expensive. However, that was the only way they can get access to it because their insurances were not covering it. Nowadays, they are starting to cover more of these, which is beneficial to your patients, obviously. However, basically what these are actually analogs of cyclic GMP, and they kind of interact with the phosphodiesterase and prevent it from working on the actual cGMP that's there. Okay. Now notice these are not completely specific to PDE5. That is important because that's going to lead to certain side effects, as we'll see. We'll get into those in a minute here. So this table, some of the important things to take away from this. Again, this is just a good kind of review table. It's not good for memorizing completely. I would not recommend that. However, looking at this is going to be important. So for instance, PDE5 is good because that's going to affect our penile blood flow. Good for the actual mechanism of action. This is anywhere else you find PDE5? As mentioned, the other use for these phosphodiesterase inhibitors is pulmonary hypertension. These are also found in the lungs as well. So PDE5, think lungs. Think the genitalia. Those are the main places you're going to find it. You're going to see that when you do that to the lungs, you're going to find increased blood flow because you're going to have that vasodilation that occurs there as well. Very good for pulmonary hypertension. Good adjuvant drug there. Now PDE6, anyone know where we find that? Actually, we found in the eyes. So one of the things you always hear about Viagra, perhaps you've heard, is people going blind from it. That is a potential side effect. We'll talk about that briefly a little bit later on. But that's due to PDE6. Anyone know where we find PDE11? It's going to be the muscles. So some of them that are affecting PD11, you can find myalgias are going to be an important side effect associated with that. So again, looking at sildenafil, you're going to see this affects a lot of PDE5 and 6. So you're going to expect to see mostly eye stuff with sildenafil. If you ever have anyone who's taking sildenafil or Viagra and never experienced any kind of changes in vision, they need to stop taking the drug immediately. You need to get switched over to something else, okay? Any kind of vision changes. And I'll talk about a kind of a unique one as well. Anyone know what color Viagra comes in? It's a little blue pill, right? So it's part of the marketing, so that's why I always knew that. They can also have a side effect called cyanopsia. You know what that means? Yeah, you kind of get a blue of the vision, right? So I remember we talked about xanthopsia with what drug? Remember back in the cardiac section, talking about antiarrhythmics. Digoxin causes a yellowing of the vision, kind of yellow greenish sort of color. This causes a bluing of the vision, so it's kind of interesting. Cyanopsia. So there's one thing to note there. PDE11, the main one's going to be affecting this is going to be tadalafil. It's actually kind of interesting. We were using this as a study drug. It actually did not pan out to work, but we were using this as a study drug for kids with Duchenne's muscular dystrophy, trying to help their muscles work a little bit more effectively, and that actually did not pan out. But you'll see a lot of myalgias associated with tadalafil. And then the other big thing to note here is going to be half-life. Half-life is going to be very important for this. Which one do you notice is the longest? Can be Cialis or Tadalafil. This is one of those ones where you can potentially take it on Friday night and you're actually good throughout the whole weekend because the drug levels stay high enough, so you can just do kind of one pill for that period of time, which is kind of one of the selling points for the drug for a period of time. All the rest of them you would have to take, say at least once a day in order to get kind of the effects from that. Okay, so those are the main things to note here. Just know that you can look at the duration of action of the drug. So again, most of these are pretty short acting for the most part. However, Cialis is going to stick around for a good long time, 24, 36 hours potentially. So very long duration of action for that one. So those are the main things to note here. So okay, so again, first line therapy for most patients, especially younger patients, very discreet. You can just pop a tablet and you're good to go. And selection typically is going to be dictated by the adverse effects the patient may experience, the onset or duration. So again, with Cialis being a little bit longer acting, it probably has a little bit longer time to onset, so may need to take that even sooner than something like a Viagra, so something to think about. And then obviously cost of treatment is a big thing here. These are going to be around 50 to 80% effective, so for most patients should receive some benefit from this. Poor responders are typically those that have like a lot of comorbid conditions, so hypertension, PVD, diabetes, things like that. So those are the ones that are more likely to need some extra assistance, either surgical means or something else, right? Okay. If they have a failure, typically you want to look at food interactions. So some things get absorbed better with fatty foods like sildenafil or vardenafil, so they didn't want to look into that. And typically you want to try between 5 and 8 doses to kind of see how they're going to respond to it, really to assess full kind of efficacy and for any side effects there. Maybe titrate up on the dose. But again, typically, think date night, going out, having dinner, having some drinks. Make sure they're not getting too much alcohol. That can definitely be kind of put a damper on the effects of the drugs here, right, from a kind of a psychogenic standpoint. And then be aware that some patients can be more at risk for developing priapism with this. So you want to avoid this in healthy patients. So again, people who do not have erectile dysfunction, who don't need it, want to avoid that. Patients with sickle cell anemia. Why do you think sickle cell anemia would affect this? What happens to sickle cell? Their blood gets pretty sludged up, right? So again, as you had that confirmation, start to get more of that hemoglobin in the sickle cell sort of formation of the red blood cells, you're going to find it gets kind of more sludge, right? That's why we see like acute chest pain, things like that. Same thing can happen in the penis, and that's why you can see priapism with that. Other things like multiple myeloma, leukemia, other things you don't want to mix with other erectile dysfunction medications. You really only use one medication at a time for these patients. So again, risk for priapism. Anyone know what you do to treat priapism? You can drain it, right? So you can use a needle and do needle aspiration. That's one way. Do you know anything else? Not Benadryl. You can actually use a drug called phenylephrine. You normally, if you think about cough and cold medications, you ever see like Sudafed PE, you can buy over the counter that contains phenylephrine. We can use that as an IV formulation. Basically, we'll instill that intracavernosally, and that will cause vasoconstriction of the arteries there, and can help to cause detumescence in that kind of case. So just a little aside there. All right, priapism, is that a big deal? Yes, it's a urologic emergency. It has to be addressed immediately, otherwise it can lead to long-term damage, right? Okay, so other things to look at. Other isoenzymes of phosphodiesterase. We have PDE6. These are mainly found in the rods and cones of the eye. So if you go all the way back to physiology, now you can watch those videos again, relive those heady days. You can see that we did talk about PDE6. I'm pretty sure I mentioned it there. Basically, though, what you can see, though, is it can lead to blurred vision. Can lead to that synopsia, any of which these are warning signs. I need to stop taking it and get switched over to something else. Sildenafil is going to be the biggest one here because that has the most effect on PDE6. Most of the other ones are going to be much less than that. So just be aware that sildenafil is a big one to think about. The other thing is going to be PDE11 found in the striated muscle. This leads to a lot of myalgias. Tadalafil or Cialis is going to be the big one seen with that. Okay, so you can keep those kind of more unique sort of side effects in mind with those ones. Now, onset, typically 1 to 2 hours or so. Probably vardenafil has a little bit slower onset, especially if it's consumed with food. So again, most of the time they're eating this with dinner, things like that. So think about that. And then as far as tadalafil, will have a slower onset, but has the longest duration of action. So again, they can kind of carry most patients throughout the weekend, which can be very beneficial from that standpoint. Some of these are metabolized by CYP3A4, especially like sildenafil. So watch for those drug interactions. You may see increased risk for priapism if they had an inhibitor on board or things like that. So watch out for it. And then some of these need to be renally adjusted. Again, they have history of renal disease. Just make sure you're checking those doses as well. Okay. So adverse effects. So due to, and again, is it only affecting PDE5 in the penis, or is it affecting PDE5 everywhere? Everywhere, right? So systemic medication. So this is where you can see things like facial flushing, cause of vasodilation. There you can see dyspepsia because it can actually cause lower esophageal sphincter tone to lessen. So you can see a lot of reflux that can happen with that. Nasal congestion, even dizziness. So again, these are kind of dose related, mostly due to that vasodilation that happens there. So watch out for that. And then you can actually see some drops in blood pressure. Most of the time they're going to be asymptomatic, but imagine if you gave this to like an 80-year-old male patient, much less likely to have that kind of hemodynamic reserve than something who's like, say, 40, right? So watch out for those drops in blood pressure. Big thing to note here, though, is you want to avoid it in patients who are on multiple antihypertensives and very particularly nitrates, right? So before you give someone a nitrate, what do you need to ask them? For male patients, at least. Are you taking any medication for erectile dysfunction? Because again, most likely it's going to be one of these drugs, and these are going to be contraindicated. You do not want to give a nitrate and a phosphodiesterase inhibitor because again, it's working on two spots on the same pathway, and what can that lead to? Hypotension, very significant hypotension. You don't want to bottom your patient out, especially when they're trying to perfuse blood to their heart in the middle of a heart attack, right? So again, that's something to keep in mind. All high-risk cardiac patients either use very cautiously or not at all, and definitely consult with their cardiologist to make sure that they're in agreement with your recommendations on how to treat this. Let's see. Again, other things, 2 to 3%, pretty rare, but you can see things like photophobia, blurred vision. Again, that's going to be more seen with sildenafil, but generally it tends to be reversible. However, there's a very rare instance where you can have this non-arteritic anterior ischemic optic neuropathy, or it's NAON, or I guess however you want to pronounce that abbreviation there. But basically, they'll have a unilateral painless blindness that may be irreversible, right? So again, if you hear that, think sildenafil. Very rare, but again, any kind of changes in vision, I would just stop taking it altogether. Okay. Mentioned the myalgias that can occur due to PDE11 being affected by tadalafil. That's the biggest one that can cause that. And then vardenafil rarely can cause QTC prolongation. So again, if they had any kind of congenital QT prolongation, they're on other medications that can do this. This is one thing to watch out for. And then priapism, typically pretty rare for the most part. But you do want to be careful if they are on multiple medications that can be used for erectile dysfunction. And especially with higher doses, especially in people who do not have any reason to be using the medication or those kind of conditions you mentioned like sickle cell, things that can sludge up the blood, these are going to be a high risk for developing priapism. But typically by itself, very rare that it would actually occur. And again, it's one of those things where you just don't take it and all of a sudden you have an erection. Like you still have to have that kind of external stimuli to cause the process to occur in the first place. Now, does anyone know how you can tell if a patient has a Viagra stuck in their throat when they take it? They complain of a stiff neck. You guys are waiting like, I don't know, how do you tell? You need to educate my patient on this. No. Okay, so I mentioned drug interactions. Nitrates are the biggest thing. These are going to be contraindicated for use with nitrates due to them causing way too much cyclic GMP to be formed. So way too big, kind of synergistic drops in blood pressure. So you need to watch out for that. Typically, we mentioned that you should have no nitrates within 24 hours of using a phosphodiesterase inhibitor, or in the case of tadalafil, because it lasts a lot longer, 48 hours, right? So you want to separate those out at least that long. If your patient has a history of angina, if they have a history of needing sublingual nitro, just use something else. Sorry, we have some other agents we'll talk about that might be better suited for them. And then how would you treat that hypotension? We can do things like put them in the Trendelenburg position. Anyone know what that is? Legs up, head down, right? So you put them in that position to get more blood flow to the heart and the head, and then give them lots of fluids, right? Isotonic IV fluids can help tank them up a little bit there until the effects kind of wear off. Typically, nitro is pretty short acting, so again, it could be kind of a transient thing, but you just don't want to watch out for it. Because again, all that nitric oxide that nitroglycerin is donating, it gets turned into cyclic GMP, it's not being broken down. So again, it's going to stick around for a lot longer than you expect. And then with CYP3A4 inhibitors, just start at a lower dose of PDE if you're a phosphodiesterase inhibitor and gently titrate up based on response. Okay, so that's it for the phosphodiesterase inhibitors. Some alternative agents we have here. We have things like alprostadil, which is another name for prostaglandin E1, right? So we mentioned that prostaglandin can be an important stimulus for an erection as well. And so we have a couple dosage forms we have here. We have this intracavernosal form, which is called Caverject or EDEX. And then we have an intraurethral insert, which is called MUSE, which stands for Medicated Urethral System for Erection. So I don't know if the band Muse had that in mind when they did that, but that's what I think of typically now that I've been scarred by this this lecture. Anywho, so instead of working on cyclic GMP, this is working on cyclic AMP. So also decrease intracellular calcium. That will lead to smooth muscle relaxation. This one's not nitric oxide dependent, which is beneficial because you don't have to worry about it using it in patients with, say, nitrates, right? It's good for patients who have deficient nitric oxide pathways, things like diabetes, or if they've had prostatectomy. These are all good cases for using alprostadil instead. Anyone know what else we use alprostadil for? I mentioned it like in the NICU section. Yeah, so you can give alprostadil for like a premature or like just a newborn who maybe has a congenital heart issue or something like that where they need to keep that PDA open. We can actually use alprostadil to do that. So we have an IV formulation we'll use in that patient population. So again, different uses for the same drug. Here we're using it for erectile dysfunction for little tiny premature babies usually, little heart defects, usually to keep their PDA open. Okay. So typically the intracavernosal is more efficacious than the intraurethral. That kind of makes sense because you're directly injecting it into the site of action. Makes sense there. And there were some other ones we used to use. We used to use things like phentolamine or atropine. We don't use those anymore though. There's too big of a risk for prolonged erections, longer than was needed. Priapism was happening with those. So really alprostadil is the only intracavernosal one we're still using. And it's very, very effective, 70–90% depending on the dose you're utilizing there. I mean, duration of action, it's kind of like a good duration of action is only 12 to 44 minutes, so you need to use it kind of right prior to having relations, and then once you're done, then it'll kind of wear off on its own. It doesn't sit and last as long as all the other ones, or the phosphodiesterase inhibitors, I should say. And then you're going to find that it's more of a vascular issue. You probably need a little bit higher dose than if it's just a strictly psychogenic issue, and this can be working kind of independent to some degree of that nitric oxide pathway. So even if they have things like spinal cord injury, this may still get some additional benefit more so than you would see like a phosphodiesterase inhibitor. And then tolerance does not appear to develop here. So again, they can continue utilizing this pretty much as long as needed by the patient. So reasons why people don't utilize this therapy very much. Why do you think they might not use intracavernosal injections? I would not want to inject anything in that general area. Most other guys would not want to do that either. So needle phobia is a big thing, right? It's also kind of inconvenient, or they might be getting old enough that they're like, it's not even worth it at this point. It's just too much hassle, right? And then also going to have kind of an increased cost associated with it. So lots of reasons, even though it's very effective, people might not want to utilize it. Basically, you're only going to inject it into one cavernosa. And again, patient education is going to be super important here because again, what do you think could be some risk with using these injections? Infection is a big thing, right? So we want to make sure they're using gloves and they're sanitizing everything appropriately. Again, educate them the duration is not expected to last more than an hour. So again, you kind of want to use it right before the act, and then it should kind of last you through that, and then you're kind of done for that point. And again, it's going to be nice because it kind of limits a lot of the systemic side effects. It's only be kind of working there in the cavernosa, has a very short half-life outside of there, so it doesn't have a lot of systemic effects. Very good for high-risk cardiac patients, things like that. So you could use about 5 to 10 minutes prior to intercourse, and then usually you're going to use a pretty high gauge needle here, only 1/2 inch needed, and then make sure you're using aseptic technique. Aseptic technique just means only lick the needle beforehand. Use it like you want to make sure you're staying pretty sterile, right? No reusing needles, things like that. These are things you might have to educate people on because they're like, I already have to pay a bunch of money for this stuff. I'm just going to reuse the same needle. Not a good idea, right? Okay. So some adverse effects. Typically, this will be mitigated by good injection techniques once they kind of get used to it. But think about older patients. What else might they have that can interfere with this process? Arthritis, rheumatoid arthritis, things that make it very difficult for them to inject themselves. Especially if they're developing things like Parkinson's and they have tremors. Think about these things and whether or not this is a good option for your patient. You can develop these kind of plaques and fibrotic areas in some patients. You can actually stop the injections for a period of time. Those should resolve, and then you can continue at that point. And then the other big thing is just kind of local pain, and then rarely priapism, but it's still a risk you want to at least warn your patient about. Okay. Next, we have the intraurethral injection. So the only difference here is instead of actually having an injection, you'll have a device that can implant. It's like almost like a little tiny suppository that will implant it into the urethra. Only thing here is you can cause urethral damage depending on their technique, and so you do have a small risk of stricture and then potential difficulty voiding. So again, just make sure they're educated on how to use that appropriately. There are some prosthetics that are available. So there's either inflatable that can be implanted to the patient, or malleable. That's the one I mentioned, kind of like a Barbie doll leg, where you can just kind of change the shape of it, and it'll kind of retain that shape for them. And those are generally pretty well satisfied by most patients. But of course, infection is probably the most common thing you might see with that. So just as an alternative. Okay, so that's it for the erectile dysfunction medications. Any questions on that? All right, if not, I'll give you a 10-minute break, and we'll come back and continue on. That work? All right, any questions about the first half? You feel pretty good about that? Okay. To follow up on the stiff neck joke, does anyone know? I know that wasn't the joke, but does anyone know why giraffes hold grudges for so long? It takes them a very long time to swallow their pride. Anyway, all right. On the test? See if you can guess the right punchline for the joke? I'll think about it. And then discard the idea, but at least I thought about it. Okay. Anyway, all right, so BPH, what is BPH? Okay, what does that mean? Enlarged prostate, or prostate is too big, and what's the problem with that? It's on the bladder, what else? Can't pee. Impinges on urine flow, absolutely. So very benign kind of neoplasm in American men, nearly ubiquitous. We're going to see why that is in just a second. What are the big determinants? What kind of helps to increase the size of the prostate? Yeah, so DHT is going to be one of the big components there. So we're going to see things that can affect DHT. What's another big component that causes kind of the squeeze of the prostate, not necessarily just the size of it? So if you imagine if a bear hopped out of the wall, say a bear hopped out and said, "Roar, I'm going to eat you," what is stimulated? Yeah, so what is stimulating that? The sympathetic nervous system should be activated, which is releasing norepinephrine, which should activate what receptors? Alpha receptors, right? So activate the alpha receptors. And what does alpha receptors do to the urinary tract? Do I need to stop and go to the bathroom while the bear's waiting for me? No, I got to run away, right? So again, it's going to be one of those things where it's going to stimulate to not urinate. So this is where we're going to see alpha agonists could actually squeeze down on the prostate. We're going to see the alpha antagonists to block that. So we think DHT, ways we can decrease that, and think ways we can block alpha-1 receptors. Those are going to be the two big things you think about when you think prostate BPH, and how we can affect that. Anyway, so let's get into this. So we'll talk about our medical management. Certainly there's watchful waiting. Again, if it's not too symptomatic for your patient, you can not necessarily have to initiate therapy. We're going to see lots of different options we have here that can assist with this. So we're going to find that most men end up developing some degree of enlarged prostate. Not all of that's going to be causing a lot of symptoms. Some people do remain asymptomatic, but usually peak around 63 to 65 years of age or so. and some people, around 60% of men at least 60 years old will develop some clinical amount of BPH, right? So again, pretty common to run into this. Again, we can see there's some ways we can kind of get around a lot of the medications we're going to have to use in regards to like how we can kind of get double duty out of some of these. Because imagine what is if I have an alpha-1 antagonist on board, what does that do to my blood pressure? Alpha-1 antagonist decreases, right? Decreases your blood pressure. So we can see if you have someone with hypertension, maybe we can pull some double duty with some of these medications, right? So we're going to see some ways we can kind of get creative and use, kind of get two birds with one stone with some of these medications here, as we'll see in just a minute. Anyway, so what we're seeing here, the prostate itself, this guy right here, a chestnut-sized gland. How many's ever seen a chestnut in person? I've never seen a chestnut. I have no idea how big a prostate is. I'm just assuming. I'm just kidding. No, I've never seen a chestnut in the real world though. So it seems like an odd size comparison, but that's what was in the book. Anywho, surrounds the urethra. Typically around 15 to 20 grams, not too large there. But what's the main purpose of the prostate? Helps secrete fluids for the ejaculate volume. Around 20 to 40% of the volume comes from the prostate itself, and it also has high zinc concentration, and so it has good antibacterial properties. Right, zinc helps to kind of inhibit bacterial growth. Kind of another feature of why guys are less likely to develop UTIs. Kind of a nice thing there. Again, because remember Dr. O was talking about females getting it because their urethra is so short. UTIs, however, they also don't have a prostate. We're losing all this kind of zinc-rich fluid, so that's another benefit there. Anywho, that's the main use for it. However, it's not going to be good if it gets too large, and so typically you're going to find two big growth periods for that. The first one's going to be around puberty, and then the second growth spurt of the prostate happens around age 40, and it'll continue up through there. The important thing here is to know the different types of tissue and to know what sort of medications or what sort of substances are going to be affecting it. So we have the epithelial or glandular tissue. This is what produces all the secretions for the most part, and so this is going to be stimulated by the androgens, right? So the main androgen affecting it is testosterone and DHT. More importantly, DHT is the thing that affects that, right? So that's going to be affecting the epithelial cells there. And typically, what do you think DHT will do to that epithelial tissue? Hyperplasia, right? It's going to cause it to grow in size, okay? Then we're going to see there's a smooth muscle tissue layer, the stromal tissue, and this is where we're going to see embedded with alpha-1 adrenergic receptors here, okay? So when I have norepinephrine activating those alpha-1 receptors, what's going to happen? It's going to squeeze down on it, and that can do what to the urine flow? It's going to impinge upon it. It's going to decrease it, right? So again, you're starting to see that you can either have the androgen effect causing it to grow and to squeeze down on the urethra, or we can have the alpha-1 effects causing it to squease down on it, kind of more of a mechanical sort of sense. And then you're going to have this capsule, this kind of fibrous connective tissue. You're going to find some adrenergic. See, this gets confusing because there's androgenic and there's adrenergic. Make sure you keep those two straight in your mind, unlike I'm unable to do right now. But anyway, it's Friday afternoon. We're all tired. But this will contain adrenergic. I'm going to rewind that. Adrenergic receptors. So alpha-1 receptors can also affect that capsule there as well. So I think the stromal, the smooth muscle tissue, the capsule, those are going to be where alpha-1 is affecting it. Mainly the epithelial tissue is going to be the androgens. That's where you're going to see testosterone and DHT mainly affecting that. So what we have here is testosterone will be converted by a 5-alpha reductase. We've talked about that previously. To convert to DHT tends to be more potent. That's where you see a lot of the male pattern baldness that happens there, acne, more potent than testosterone in general, but will induce prostate growth, right? So this is where you see enlargement of the epithelial tissue. Estrogen tends to be a byproduct of androgen metabolism, mainly via aromatase, right? And this can also lead to some stromal growth, but not going to be the main feature here. The main feature is going to be the DHT effects we're looking at. So two factors that can affect this is the dynamic factors and then the static factors. Static factors are ones they change or they don't change. They don't change. They're static. They're going to stay right where they're at. This is where you're going to see mainly the androgen effects are going to be by causing enlargement of the epithelial tissue, right? So again, prostatic enlargement will physically block the bladder neck, okay? So this is mainly we're going to see that if you're mainly having patients with static issues, we can deal with this with something like a 5-alpha reductase inhibitor. Versus if it's more of a dynamic problem here, you're going to find that this is going to be more of a dynamic factor. It's going to change based on kind of what's going on with the patient. More norepinephrine being released, the more squeeze on those alpha-1 by those alpha-1 receptors, you're going to see more impingement there. And this is where you can see things like stress or pain can cause this to occur. And again, this is going to be more kind of an intermittent issue than you would see with just the static factors. Okay, does that kind of make sense? Okay. So basically you can see that symptoms from static and or the dynamic factors here. So you can see obstruction just with normal prostate size. That would be mainly due to the dynamic factors. That would basically mean you have a normal sized prostate, but the alpha-1 is going to be too overactive and will cause squeeze and cause an impingement of that urine flow, right? However, if you have an enlarged prostate, it could be kind of a double whammy there. We have both static and dynamic factors that are playing a role. And this is going to be important because we'll kind of dictate what sort of drug therapy we're going to do. So if I have a normal sized prostate, but they're still having symptoms of BPH, or am I going to get a lot of bang for my buck out of using something like a 5-alpha reductase inhibitor? Probably not, right? Because I don't have a lot of those static factors. However, this is where something like an alpha-1 blocker can be very useful. Okay, so kind of keep that in mind. Think about kind of what the main problems are here and what drugs can target that. So again, you're going to see that with more moderate to severe voiding symptoms, usually going to be related back to increasing prostate size. We just know it's going to keep growing as the patient gets older. It's a known fact. You're going to see more likely to be static factors playing a role in addition to some dynamic factors as they get older. So looking at medication-related symptoms, so if I'm giving you more testosterone, it means I'm going to have more testosterone available to convert to DHT. That can lead to BPH symptoms. We know that. Adrenergic agonists, so we can have things like pseudoephedrine. Where do you find pseudoephedrine? Yeah, Sudafed, a lot of cough and cold products. Can you find this over the counter? It's behind the counter, technically, right? So you don't need a prescription, but it's behind the counter. So potatoes, whatever. But again, it is important from a regulatory standpoint. Ephedrine, which you don't really find too frequently anymore. But then phenylephrine, we mentioned previously when we were talking about priapism, but you find this in some cough and cold products as well. So you see Sudafed PE is just there on the shelf. That's what that's referring to. Again, is like Sudafed PE, is that very good for dealing with nasal congestion? No, go for the good stuff. Go for the behind-the-counter stuff. Sudafed's going to work a lot better than this phenylephrine nonsense, right? But can also cause the alpha receptors to be activated and cause those dynamic factors to impinge upon urine flow. Okay. Other things. What do you think anticholinergics are going to do? Usually acetylcholine causes what to the detrusor muscle in the bladder? Should squeeze it, remember? So remember that it's kind of the opposite effect you think when doing the bladder, where if you have parasympathetic activation, acetylcholine is going to cause squeeze on the detrusor muscle, is going to cause the urine to flow, right? So if I have an anticholinergic, remember anticholinergic, what are the side effects of that? Remember the mnemonic? Mad as a hatter, dry as a bone. Remember, that's the main thing here. So you can see urinary retention due to anticholinergic. So what are drugs that can cause anticholinergic effects? It's on the slide. Antihistamines, TCA, first generation antihistamines, TCAs, phenothiazines, all those have strong anticholinergic components to it, right? So those tend to cause urinary retention, which can not directly make the BPH worse, but can work in tandem with it to make it more difficult to void urine, okay? See how these things are kind of playing a role with one another. So looking at the actual symptoms that come about from here, if it's more of an obstructive problem, this is where you're seeing this prostatism or this bladder outlet obstruction. Typically, you're seeing decreased flow rate. You're seeing bladder emptying as either incomplete or slow. Did anyone ever see there's an SNL commercial? They did like a fake commercial a couple of years ago where they were doing like a fake BPH drug commercial, and basically there's a guy with a garden hose and it kept getting kinked, and there's like really not a whole lot of water going out, and he looks over at his neighbor and he's just like blasting water from a fire hose everywhere. Basically it's kind of like that, right? So you're kind of preventing urine flow as it should be. So you have this urinary hesitancy, bladder overdistension that can happen, which can lead to some other problems kind of chronically, as we'll see a little bit later on when we talk about urinary incontinence. Anywho, these irritative symptoms, these are the chronic issues that it can occur here. So it's later in the disease course, and basically this is due to long-standing bladder neck obstruction due to kind of this chronic backflow that's occurring here, this back pressure. And basically you're going to see the bladder muscle hypertrophy. What do you think that is? It's got to squeeze harder to push all that fluid out, right? So you got to have increased pressure to make sure it can get past that obstruction there. You see that the bladder becomes very hypersensitive and is very ineffective. So very small changes in bladder volume can lead to that urge to urinate. So you can see some major issues with that. You're going to find that you're going to have increased urinary frequency, increased urgencies, where you can see like bedwetting start to happen here. And again, it's a question: patients are getting older. Is it related back to their dementia or Alzheimer's, things like that, or is it just due to the fact they have BPH? And this is kind of a long-standing issue for them. If they're having urinary incontinence. So things to look at. What can happen with nocturia with older patients as well? yeah, they kind of falls, right? So they get up in the middle of the night, they trip over something, fall, fracture, not good. Okay. So anyway, so again, symptoms not always going to be progressive, but around 1/2 to 2/3 of guys are going to be, I'm sorry, 1/3 to 2/3 of guys are going to stabilize. They may improve without treatment. So this is where that watchful waiting kind of comes into play here. And of course, what's the other thing you are concerned about if you see someone with BPH? Prostate cancer, right? So you're going to be screening for that as well. Especially men of a certain age, you're going to do that. And of course, you're going to be tracking these lower urinary tract symptoms. Again, this is where you can see some other issues that can pop up here, like UTI that can develop, neurogenic bladder. So these are things to watch out for. Again, rarer, but it can still occur. Okay, so I mentioned other complications that can happen here. So again, acute urinary retention can lead to acute renal failure, potentially. It's very severe. You may see some hematuria, overflow urinary incontinence, which we'll talk about that a little bit later on, UTIs, bladder stones, chronic renal failure. All these things are no good. So this is why we want to treat this early, kind of prevent it from getting any worse. All right, so looking at our flow chart here, we can see with BPH, you can start off with just mild symptoms. Watchful waiting is totally fine here if they're not that symptomatic. However, for more moderate symptoms, we can see that we can, based on, what their prostate size is and based on other concomitant conditions, we can start to gear our therapy more appropriately. So, for instance, we can see that when we're dealing with erectile dysfunction on top of BPH, we can get away with a certain group of drugs. And we'll talk about these more in detail, but you can reference back to this as we go through it and kind of get a feel for what to administer. But again, look, small prostate with low PSA. Notice here, why do we use an alpha adrenergic antagonist? Small prostate, you're not really worried about those static factors. It's all dynamic at that point, right? Versus large prostate is we're going to be utilizing more of those 5-alpha reductase inhibitors. So keep these things in mind. All right. And of course, what could we always do at the very end of the day? Is Dave Coulier might say in Full House, just cut it out, right? The other thing you could potentially do. But we'd like to avoid that. I'd like to stick with the drugs if we can. I don't remember what his name was in the show, though. Is it no, Jesse was John Stamos. Joey, there we go. Uncle Joey, yeah. All right, anyway. Yeah, sure you do. Okay, I don't know what that means. Anywho, right, so desired outcomes, obviously we'd like to prevent any kind of long-term complications. That's going to be great. We'd like to reduce the need for surgical intervention if possible. And then, of course, we'd like the treatment to be kind of well tolerated. We'll see there's side effects associated with all of these we want to watch out for, and also be cost effective. So looking at our pharmacologic therapy, we're going to have drugs that will cause relaxation of the prostatic smooth muscle. So again, we've kind of talked about these reducing the dynamic factors. This will be our alpha-1 antagonists. These are going to be the most common agents used here. However, these do not decrease prostate size. Really, the only thing that increases or decreases prostate size is going to be either presence or lack of androgens, right? So again, alpha-1 blockers do not do anything to prostate size. To reduce the testosterone effect, we're going to be seeing this will help to reduce static factors, and this is where our 5-alpha reductase inhibitors come into play. Okay, and then agents that can help to relax the bladder detrusor muscles, or antimuscarinics can be utilized. And again, I mentioned this can actually worsen BPH in some cases, but there are some instances where you may want to use it, and this may help to reduce some of those irritable voiding symptoms. This is going to be for more kind of late stage, more chronic disease. We'll see when that would be appropriate for our patients. Okay, so selection needs to be on a case-by-case basis that we've kind of alluded to already. And again, the benefits are only going to last as long as the medication is taking, right? So if I were to give a patient who has a large prostate, a 5-alpha reductase inhibitor, and it shrinks down, what would happen if I took that away? It goes right back to the original size because I've not done anything to their testosterone production. I'm only decreasing the amount of DHT that they're making, right? So again, it's only going to work while it's around. Similarly for the alpha antagonists, if I take those away, problems are going to go right back to where they were before, right? Alpha ones tend to be used first line. They tend to have fewer side effects and also going to be more rapid acting. Because what could happen with a 5-alpha reductase inhibitor? What side effects might you imagine? Gynecomastia. You imagine more kind of feminizing sort of effects, more estrogen sort of based effects than you would expect to see otherwise, right? Because we're reducing the amount of DHT they're forming, which tends to be more kind of masculinizing. We'll look at that in a second. Again, 5-alpha reductase inhibitors are preferred for cardiovascular patients, or if they have significantly large prostate. So why do you think it's better for CV patients? So what do alpha-1 blockers do to your blood pressure? Decrease it, right? So again, if you're dependent on having that high blood pressure to make sure you're perfusing the coronary vessels, that could be a problem if you all of a sudden decrease that. So again, high-risk cardiovascular patients probably want to avoid the alpha-1 blockers. We'll look at some examples where we can get around that a little bit by using something that's more selective, but that'll be in a second here. Okay. In some cases, you may need combination therapy, depending on severity of symptoms. So, patient with erectile dysfunction and BPH, you may actually find that by using a phosphodiesterase inhibitor, you can have some relaxation of that stromal tissue there, that smooth muscle. It tends to be less effective. However, if it can pull some double duty with this, that can be beneficial for your patients. However, I don't see too many people who are utilizing this. Again, usually due to cost and some other factors there. And in patients with irritative symptoms, right, so they've had that kind of long-standing sort of bladder outlet obstruction. This is where you can add on anticholinergic to try to loosen that bladder muscle up, that detrusor muscle, a little bit more to try to hold urine a little bit better. That can be beneficial. Just make sure they don't have a really high kind of post void residual. Otherwise, you may need to look into some other issues with that. At that point, you may need things like catheterization and whatnot. So again, we like to avoid that, but because again, what can happen with catheterization for these patients? Infection, yeah, that's one of the big things you want to watch out for. Okay, so looking at our alpha-1 antagonists, we have 3 main generations. So we're going to see the first generation. We don't really use these too much anymore because remember, as you decrease blood pressure, as you vasodilate the arteries, what does your heart want to do in response to that? Yeah, it wants to increase cardiac output, right? Because SVR has gone down, so cardiac output has to go up to compensate for that. So you saw a lot of tachycardia. You saw a lot of arrhythmias associated with the first generation. So those are no good. We don't like those. We have some second generation agent ones. These are going to have no alpha-2 antagonism, which clinically will have some minor importance here. But the main thing I want to focus on here is the third generation agents. These are going to be uroselective, meaning they're affecting a specific subtype of alpha-1 receptor that's going to be mainly found in the prostate, not really anywhere else, right? And so we'll look at some agents there. Typically, the second and third generations have equal efficacy from a clinical standpoint. However, the third generation agents are going to limit side effects. Again, probably going to be more expensive in the long run as well. And remember, these do not affect prostate size, only affect those dynamic factors. So our second generation agent ones, we've talked about these before. We've seen these with hypertension. If you go back to those lectures, things like prazosin, terazosin, doxazosin, and then you have also this one called alfuzosin. We didn't talk about that one before, but this one tends to get marketed more for BPH. Uroxetrol is the brand name for that one. So you see uro, think urology, think BPH. It kind of leads you to think what this drug is used for. Main dose effects, though, as you might imagine, it can cause acute decreases in blood pressure. This can lead to orthostatic hypotension, so you can see first dose syncope. When do you think you might want to administer this drug for patients for the first dose? Probably around bedtime. That way they're going to be asleep anyway. They may not have a whole lot need to get up in the middle of the night. So that may be a safer time to administer that. That way they're not having to worry about standing up and getting super dizzy and falling and all that fun stuff. So again, you want to start very low dose with these and gently titrate up, especially the older the patient is, the less hemodynamic reserve they probably have. And again, dose it at bedtime and titrate over several weeks, right? It's not something you want to try to give them full blast right off the bat there. So this will also be synergistic with their other antihypertensives. So for instance, if you had someone who's on lisinopril that really wasn't cutting the mustard and their blood pressure is still a little higher than you'd expect it to be, you can add on an alpha-1 antagonist and their BPH improves and their blood pressure improves. 2 birds with 1 stone. That can be a beneficial thing there, right? Now, prazosin we don't like so much because it has the shortest acting. You need anywhere between 2 to 3 times a day dosing, so we don't like that one quite so much. However, doxazosin and alfuzosin are longer acting, and these are going to be better off because the patient takes it less frequently. You're going to see less kind of big peak dose sort of effects, less likely to see that big drop in blood pressure, that orthostatic hypotension like you would see with a shorter acting agent. And so again, we see the alfuzosin, again, that's marketed for BPH, tends to have the least amount of systemic side effects. And really actually no dose titration related to that one. It's kind of a benefit. So again, I'd probably recommend going with this one if you needed to use the second generation. However, we're going to see if a few other third generations will be even better from a side effect standpoint. So here, we're going to see we have something like tamsulosin or Flomax. I've never heard of Flomax before. Had a lot of commercials for it back in the day. This one you do want to avoid in sulfa allergies. That is a cross-reactivity you have to be careful of. So watch out for that. There's silodosin or Rapaflo. This one I don't see used too often due to a lot of drug interactions that happen here. So really tamsulosin or Flomax is the most common one. And again, the brand name kind of directly informs what the drug is used for, right? So Flomax, think BPH, think of the garden hose, right? I'll remember what it's for. And so a big thing here is it's going to be directly targeting alpha-1A receptor, so it's again more specific for the prostate. It kind of lacks a lot of the blood vessel sort of effects you would see with the other second generation sort of agents there. So again, that's a big benefit with this one. Fewer side effects. If I mentioned, on a test question, something like, a 70-year-old guy, BPH, was taking prazosin and had a fall secondary to that, what would you recommend as a alternative? mainly having dynamic factors, you might say something like, tamsulosin would be a good option for them, right? So those are kind of things you want to think about as far as, drug selection for your patients. Which I heard there wasn't as many case vignettes on this last test as there usually are, so I said, oh, maybe that was my downfall. Maybe I need to put more case vignettes. Make you guys do a little bit more critical thinking, I think, right? No, I see a lot of no's. I see a lot of please no's. Masterfully, yeah. I mean, your words, not mine, right? Just kidding. Just kidding. No, I really don't change my test. It's a stream of consciousness. I usually kind of go into a fugue state for a couple hours, and I wake up and it's like 50 questions. All right, here we go. Usually, mescaline's a hell of a drug. That's all I'm saying. Anywho, so looking at using an alpha-1 blocker plus a phosphodiesterase inhibitor, you can see some synergistic drops in blood pressure, so do watch out for that. However, you're least likely to see the effects with tadalafil. Makes sense because it has a longer half-life, less kind of a peak dose sort of effect. And then tamsulosin being so selective for the prostate as opposed to the blood vessels, you get a lot less effect here. So again, if you had to mix those two, that would be the preferred combination, right? However, tadalafil you would not want to mix with what? Nitrates, remember contraindication? Don't mix with nitrates, right? Too much hypotension. Okay, then on the flip side, we have our 5-alpha reductase inhibitors. This is where we're going to have our finasteride, which is a Proscar. And it's going to be affecting a specific subtype of 5-alpha reductase. And again, this is mainly the type that's found in the prostate. So the goal here is to try to shoot for as much of the DHT or the DHT production in the prostate. We're trying to limit the effects more systemically because, again, you worry about the side effects you see with that. And so we can find that by targeting this type 2 5-alpha reductase, you're going to decrease DHT levels by about 80 to 90% in the prostate, but about 70% drop in the serum, right? So again, it's a little selective, but you're still seeing a pretty big drop systemically as well, so you can still see some side effects there. Also, dutasteride is going to be a non-selective inhibitor. This can decrease DHT levels systemically by about 90%. And this is going to be better for patients with enlarged prostates. So we'll have to help shrink that down and deal with those kind of static factors there. Both of these are going to be equally effective. Who do you think should not be handling these drugs? Who do you think might have really kind of untoward side effects? Kind of a bad question, but what I'm trying to get at is these are very teratogenic. We actually recommend female patients of childbearing potential do not handle these drugs without gloves due to the fact that these can have very significant effects if there's any exposure to a fetus. So category X, even though there's not really good indication when you need to use these for a female patient, right? Because again, female patients don't have a prostate, absolutely. So looking at 5-alpha reductase inhibitors, again, these are good for patients who cannot tolerate an alpha-1 antagonists. If they had any kind of like high-risk cardiovascular histories, might be a good option to use for them, but could be used in combinations. You may see something like a finasteride plus tamsulosin. Totally seen that before very frequently. And you can see, reduction in prostate size by about 25% or so. And so you may actually reduce even the prevalence of prostate cancer over time because you're decreasing that kind of the pro-testosterone sort of effect you're having there on that kind of the hyperplasia. However, versus an alpha-1 blocker, you're going to see it has a slower onset, more likely to see sexual side effects. Again, really back to decreased DHT levels on effects on libido and things like that. And so typically, if they're sexually active still, probably use it as a second line. Alpha-1s are going to be preferred. Use these as a second line if needed. Okay. All right. So these can be used long term, but again, as soon as you stop taking them, you're going to see prostate size will increase back to either pre-drug levels or maybe even larger, depending on how much DHT they're forming now. And I mentioned the sexual dysfunction is a big thing here. So either ejaculation disorders, usually related back to things like decreased prostatic secretions, can be a thing there. Erectile dysfunction due to you have some inhibition of nitric oxide synthesis, I should say, and then decreased libido. That's the big thing here. So other than that, other side effects, gynecomastia, some abdominal pain, pregnancy category X. So again, we have like policy set up like, hey, don't even handle these if you're a female of childbearing potential. If you're a guy, no problem, you're good to go, right? Okay. So we mentioned phosphodiesterase inhibitors. These are better for patients with BPH and erectile dysfunction at the same time, but you may find they can kind of counteract these effects a little bit, mainly due to the fact that these cause the smooth muscle relaxation. But again, if you need to use both at the same time, like an alpha-1 blocker and for phosphodiesterase inhibitor, it can be used. Just be aware of that kind of synergistic effect with the alpha-1 blockers. But again, probably tadalafil is the most studied one, just mainly due to its duration of action there. Okay. I mentioned anticholinergic agents are going to be better for kind of those long-term sort of obstructive, irritative sort of symptoms. So you want to utilize this kind of later in therapy. And mainly this is just to help to kind of relax the detrusor muscle, allow for better storage of urine within the bladder. We'll talk about this more. We talk about urinary incontinence a little bit later on in this section. And then we mentioned surgical intervention. This is going to be the gold standard prostatectomy. Again, this is going to be really kind of relegated to patients with kind of unresponsive symptoms to medications. And again, can lead to lots of complications afterwards, or they're having complications of BPH. This might be another indication for surgery. But again, we like to hold off on that as long as we can by utilizing these drugs if possible. Okay, what time is it? Would you guys be sad if I went on for 3 more hours? Trolled you. No, just kidding. Yeah, I don't. I'm gonna have a little bit of extra time for this section, which is nice. So I think I might let you guys go now, and then I'll finish this up next time. Ooh, I got a slip clap. Yeah. Never had such an effect on 63 people at the same time. Okay, yeah, I'll let you guys go. Any questions before you go? Okay, I'll see you guys next time. Yeah.